Good afternoon. I'll be presenting the case. I'm a first-year resident, internal medicine. I've just finished my hematology rotation. So this is NKD, presented to us about 2 weeks ago. A 32-year-old female, Uganda, married, from Kawempe. She's a practicing assistant, also an economist. So she presented to us with a 1-day history of shortness of breath and hemoptysis. So she said that she, while seated at home in her sofa, she suddenly developed this shortness of breath that was characterized by fast breathing. She said it was worse on lying flat. And this was associated with a history of retrosternal chest pain that was constant and could not be relieved by any analgesics. So approximately 5 hours later, she noticed a cough that was productive of pink salty sputum, and she had 2 episodes of this. However, she did not report any history of epistaxis, hematemesis, or hematuria, and significantly, she didn't have any ecchymosis on the skin. She had a history of palpitation and effort intolerance, especially trying to walk from where she was seated to the bed. She said she felt difficulty. She did not feel dizzy. She did not lose consciousness. She didn't have any fevers, and she did not report any history of body pain at that time. Significantly, she had been treated for DVT while she was pregnant, and this had happened about 6 years prior to this presentation. By that time, she did not have any history of calf swelling or pain. So, when we reviewed the other system, she did not report any history of headache, confusion, or convulsions, or any localized body weakness in the central nervous system. She didn't have any abdominal pain, abdominal distension, vomiting, or diarrhea. She reported a normal urine output basically that week. She did not have any history of dysuria, frequent hematuria. She had no history of prior joint pain, swelling, stiffness, or muscle aches. So past medical history, this was her second admission. The first was 6 years prior to this presentation because of the DVT. She reported that she developed the DVT at 16 weeks, which was treated throughout the pregnancy, and then anticoagulation continued for 3 months postpartum. She did not have any history suggestive of hypertension, DM, cardiac disease, renal disease, stroke, or any malignancy. She was HIV seronegative at that time, and she denied any history of use of contraceptives or hormonal replacement therapy. So in the past obstetric and gynecological history, she had 1 child, 6 years old now. She did not report any history of miscarriages, and her family planning method was common. So she does not have any history of past surgery or any major trauma, and she had never been transfused. So family history, she is a married woman, 1 husband, has 1 boy, 6 years, who was well. The third born in a family of 6 children. All siblings were alive and well. Both parents were alive, but the mother was on treatment for hypertension. No family history of any rheumatic disorders, no family history of diabetes, and no family history of any malignancy. In the social and occupational history, she lives in Kawempe, a suburb of Kampala, and works as an economist for a private firm. She said she spends most of her day at her workplace usually seated on the computer. He was a practicing Anglican who prays every Sunday and occasionally takes a glass of wine over the weekend, but no history of smoking. She thought that she had a pneumonia and she was concerned about the hemoptysis and also inability to work because of the illness. She expected to get better and return to her work. So in summary, I presented MKB, 32-year-old female, mother of one, who had a history of pregnancy-related DVT, who came to us with a one-year history of shortness of breath and hemoptysis that was associated with chest pain, palpitation, and effort intolerance. There was no history of loss of consciousness, no history of diabetes, hypertension, and no history of smoking. So at this point, we thought that this patient, in view of the past history of DVT, and then she's coming in with sudden onset of shortness of breath and hemoptysis, we thought she could be having an acute pulmonary embolism. And then we couldn't also rule out acute pulmonary syndrome in view of the retrosternal chest pain and shortness of breath. And pneumonia was one of the differentials as well, in view of the shortness of breath, and some pneumonias can give you hemoptysis. We also thought that probably this could be left ventricular failure with acute pulmonary edema. Maybe if she had a structural heart disease that was not diagnosed previously, and now it is decompensating to have acute pulmonary edema. The other differentials were highly unlikely but were considered. In the 32-year-old female, she had no history of exposure to, for example, stone quarrying, no history of smoking. There was no history suggestive of any connective tissue disorder. So the diagnosis of interstitial lung disease in this patient was unlikely, but possible. We also thought, could this be one of the pulmonary hemorrhagic syndromes? Good pastures could give you a hemoptysis. However, patient would have renal involvement, but significantly the patient did not have hematuria, so it was unlikely. The same with granulomatosis with cholangitis. Presents more with rhinitis, may have hemoptysis and renal involvement, but it was unlikely in this patient. Also, given the hemoptysis and the sudden onset of shortness of breath, we thought, could this be a lung malignancy that is presenting at this time? But we are not sure at that point. So we went on to examine the patient. On the day exam, she was sick looking. Her temperature was 36.7. Significantly, she had no lymphadenopathy. Did not notice any digital clubbing. She had no jaundice, no cyanosis, no edema, no pallor. She had no calf tenderness. Extremities were warm. Her weight was 83 and the height of 160 centimeters, giving us a BMI of 32, which is obese. Her vitals, the blood pressure was normal at 124/78. She had a tachycardia of 110, pulse was red, the pulse rate was regular. She was tachypneic at 22 breaths per minute and she was saturating at 93% of room air. So in the respiratory exam, she had this tachypnea of 22. She had normal breath sounds. We did not identify any grapples. She had no bronchi. Cardiovascular system. She had a regular tachycardia. Her JVP was not raised. The apex beat was a bit difficult to appreciate because of the obesity. but ultrasound 1 and 2 were hard and normal. We did not identify any features of pulmonary hypertension at this point. She didn't have a loud P2. She did have tricuspid regurg. Central nervous system, she was conscious. Her pupils were equal and reactive to light. Her neck was soft and coming negative. There were no craniopathies. She did not have any lower limb or upper limb weakness. The muscle power in both left and right upper and lower limbs was normal. She had normal sensation and normal joint position sense. So the abdomen was distended but moving with respiration. She didn't have any palpable masses. There was no hepatomegaly, no splenomegaly, and she had normal bowels. So at this point, So I tried to take a picture of the ECG. Significantly, it showed a sinus tachycardia. We can see that before every QRS, we have a P wave, that the rate is high. We did not see any T wave inversion or Q waves. We did an echo. It showed the dilated right ventricle and right atrium. The right ventricular systolic pressure was 60, which was significantly high. So we thought, and she was tachycardic all through the study. So we made an impression of a moderate right heart dilatation with severe pulmonary hypertension. We did a troponin that was elevated. I indicated probably she was having right ventricular dysfunction. Yeah, we did a D-dimer in this patient because we could not access the CT angio immediately. So we thought if we could have a D-dimer and start the patient on treatment as we await. Although from our scoring, she was more in the high probability by the modified world, so the D-dimer was not really indicated. We did an ESR. Some connective tissue disorders could present with a high ESR because we had it in our differential. The CBC was basically normal. Renal function was also normal. So with that, we made the diagnosis of acute pulmonary embolism complicated by corporal now, and then went ahead to manage the patient. We started her on oxycodone 80 milligrams twice daily, and warfarin, and we're also managing the pain with paracetamol. So a little bit of progress. After about 4 days on 80 milligrams of clexane and warfarin of 5, the INR was 1.51, but the patient had improved clinically. The oxygen saturation was much better and she was able to walk around. We increased the warfarin to 7.5 because we hadn't achieved warfarinization. Then 4 days later, she was in the therapeutic range and decided to discharge her on the dose of 7.5 and then to follow up the patient in the hematology clinic for possible lifelong anticoagulation.